we'll start with some questions now, and then we'll go to the final slides that we're going to show. So if Ben's ready, we'll do that. And the chat screen can be enabled again as well. Hi, Ben.
Hello.
Did you get to see some of that?
Yeah, I've actually seen the film before.
Oh, I thought you would have. I thought you would have. Yeah, fantastic. So if people have got questions that they want to put in the chat, they can, or they can raise their hands. As well, I'll just go now to the questions that we have here, Ben.
Fire away.
Okay, first question here is, well, I think you've already got that one, but is there any evidence to suggest that psychedelics create suicidal tendencies in individuals? Is the question that was asked before this film.
There's a number of ways of looking at a question like that. Firstly, a lot of the patients we work with all kinds of mental health problems already have ongoing suicidal issues. So we mustn't shy away from using novel treatments just because of that, or we wouldn't be able to do any work with any patients ever. And the kind of safeguards that we put in place around suicide risk issues are the same ones that we'd put in with any patient, which is about regular assessment and monitoring and having support systems in place. So they're no different from other medicines in that respect. It's certainly true that the psychedelic experience, when unprepared for, unguided and unsupported, and crucially unintegrated afterwards, can be a difficult and frightening and challenging experience for people. I think there's a lot of urban myths around the whole jumping out of windows thing. You know, suicide is something that is a risk with all psychiatric patients, and one we must all be very aware of, but it's certainly been overblown in the media, the idea that they just trigger suicide. And with all the correct safeguards in place, there's no reason why this can't be very adequately managed within the clinical setting.
Well, thank you for that. That's a great answer. And well, very interesting. You know, 8 of the 10 participants did go into remission from this trial. There's a question here that says, what happened to 2 of the 10 participants? I don't know if you know the answer to that, Ben, but I mean, an 80% remission rate on a trial is pretty exceptional. I don't know if you want to comment on that at all.
It's extraordinary. I mean, let's not forget, we're working here with treatment-resistant patients. These are patients who, despite all the very best that modern medicine can throw at them, continue to be severely disabled by their PTSD symptoms their whole life. This is after trying all the traditional medicines, in and out of hospital, suicide attempts, endless tries at psychotherapy that are ineffective. And even with all that, we have a 50% treatment resistance within PTSD, even with the best we can throw at them. So a trial that demonstrates an 80% remission is indeed remarkable. And we need to look at the 20% who don't, and look at what we can hone and improve for the future.
Thank you. And then there's another question here that says, Ben, do you find it challenging at all to maintain the professional distance required of a doctor-therapist-patient relationship during MDMA psychedelic therapy, especially given the overwhelming feelings of love which are commonly experienced? And furthermore, how can we control it such that this isn't exploited?
Well, I mean, again, it sounds like a rather boring answer, but this is nothing to do with psychedelics. This is, are you a good clinician in the first place? If you're an experienced clinician who spent many years working with traumatized patients in all sorts of different settings, homes, schools, hospitals, police stations, you have experience and you are well aware of the safeguards around boundaries and appropriate management of trauma cases. So in a way, there's no special answer to this. You apply the same management techniques that you would with any patients, which is all about mutual respect and a good understanding of safeguarding issues around consent and confidentiality, no different than for any other clinical input.
Yeah.
Obviously, with MDMA and other psychedelics, the patient is in a particularly, I wouldn't say vulnerable state, but certainly an opened or unusual state of mind. And this is why preparation sessions are so important. And the patient is well aware of what they're going to be going through, and the clinicians are experienced and specifically trained in that modality. And when all that is applied, there's no reason why there should be any extra risk of unsafe practices. There are some other particular interventions that we use. It's very common to video all of the non-drug and the drug-assisted sessions with MDMA and psilocybin therapies. This is helpful in many ways. It's helpful for training purposes to review the sessions, and it also provides a safeguarding level for both the patients and the therapists, because you've got video evidence of what went on.
Yeah.
And the other way of managing this is, if you have very clear boundaries and rules set out before you have the treatment around issues such as touch and where and when that might be appropriate and what might not be appropriate.
Yeah, thank you. There's so many questions here. I'm gonna give you some quick questions and quick answers. They're flooding in. This is probably a very good one for you, given your work with young people. All the participants shown in the film had experienced discrete traumas in adulthood. Is there evidence or research into efficacy of MDMA treatment for chronic childhood trauma?
I'm not sure. Does the question mean trauma that arose in childhood and is expressing itself in adults, or
I think so, yes.
or treating children with MDMA?
Oh, I know. I think it's about. Well, I think no. The question is about. I don't think it says about treating children. I think it's for MDMA treatment for people who've experienced childhood trauma. So
Yeah.
adults,
Well, I mean, okay. So the bottom line is the vast majority of adults with PTSD have had experience of child trauma. Even with index trauma events that occur in adulthood, like a single discrete episode like combat PTSD or an assault or a rape in adulthood, what we often see is the people who develop PTSD had pre-existing attachment difficulties associated with childhood trauma. So a good example is if you take 100 people into battle, expose them all to a traumatic experience, 95 of them will come back fine. 5 of them will come back with combat PTSD. But when you look further into their childhood histories, hey presto, they happen to be 5 people who were abused as children. So there is a very strong link between childhood trauma and adversity and subsequent adult PTSD.
Thank you. Now this is an interesting question, and I think we have a very positive answer for this one, but I'll give it to you anyway. Ben, is the word cure PTSD more realistically manage PTSD, as in the person's asking PTSD doesn't disappear altogether but is managed through successful treatment? What's your answer?
This is a great question, and it's one I talk about often in my talks. I think in psychiatry, we have become very learned helpless to the point where we almost consider ourselves palliative care doctors, that we can never cure people. All we can do is get alongside them for life. I don't believe this is good enough. I believe we can start having more hope and positive enthusiasm for our own abilities to actually cure people. Most psychiatrists would laugh at that idea because we've become so helpless within our own profession that we don't cure, we just look after. I think that the psychedelic therapies and MDMA offer us the best innovative approach to psychopharmacology and combined psychotherapy that we've ever had, and really should allow us to start moving towards the idea that we can cure people. Now, of course, you can't make something go away that occurred. If a trauma happened, it happened, and we can't turn back the clock. But what you can do with effective drug-assisted psychotherapy is reappraise what that meant and how that impacted on the formation of rigid narratives that hold back a person for life. We need to start moving away from the idea that we can't cure people. I think we can.
Mm-hmm. Absolutely. And one of the incredible things about those phase 2 trials with MAPS and the FDA, showing that 67% of people went into remission at the end of 12 months after that trial. That was an increase on the 52% that went into remission immediately after the trial. That none of those 67% of patients qualified whatsoever as candidates with PTSD at the end of that period of time. And that shows that what you're saying is absolutely possible, and it's the greatest hope that psychiatry and mental illness has seen in a very long time. So we always get lots of questions in these sessions about people wanting to get on trials with PTSD, get treatment with MDMA, etc. And I will just say to everyone that if you are seeing a psychiatrist, we encourage you to ask your psychiatrist if you've tried a number of different treatments to apply for you as a treatment-resistant patient for what's known as the SASB Scheme in Australia, which is a special access scheme which enables psychiatrists to apply on a case-by-case basis for patients who are in danger and are treatment resistant. And a psychiatrist in New South Wales has just received the first approval in Australia for that treatment. So if there are people like that, and I see a few questions like this, please feel free to reach out. Hopefully you have got a psychiatrist or someone who's supporting you, and we can provide pro forma forms that your psychiatrist can use to apply and give you some support for that sort of application. What sort of dosage of MDMA do they use in the sessions? Another question here.
The dosages that we used were those that Michael Mithofer and Annie Mithofer used in their initial phase 2 studies, which were, we offered 2 sessions of MDMA, which were sandwiched between non-drug preparation and integration sessions on a weekly basis. We dosed on weeks 3 and 6 of an 8-week course. Each MDMA session, they received 125 milligrams of MDMA initially, and then half that dose, 62.5 milligrams, 2 hours later. So 187.5 milligrams of MDMA over the course of the whole day, which occurred on 2 separate occasions during the course.
And in terms of people that have complex trauma, so multiple traumas, have you found as good results with those as people who might have just one trauma?
Yeah, I mean, as I said, most people, when you dig down into their history, have complex trauma. Yeah. The thing about the attachment relationship in those early formative years is if you have a positive attachment and a nourishing and warm and nurturing childhood experience of love and protection, you are very resilient to later trauma. And indeed, you could then experience adult trauma episodes and not develop PTSD. So the majority of people who develop chronic PTSD have had complex trauma. And the majority of patients with most mental illnesses describe what I would call at least small t trauma. In other words, a relatively poor experience of childhood and attachment. And of course, also many cases with what I would call big T trauma, which would be the bigger, more social services type things like physical or sexual abuse. But I always say, don't take your eye off the ball when it comes to emotional abuse and neglect, as these are very common throughout childhood and have a significant impact on how one's psyche develops and how resilient or vulnerable one might be to later trauma.
Yeah, thank you. And we have questions here. Does best practice require that 2 therapists be present? How long would an MDMA-assisted session last?
Yeah, so most of the protocols, indeed all of the protocols in psychedelic therapies with MDMA or psilocybin or others to date have been a 2-therapist pair, and they've also traditionally been a male-female pair. That's often because a lot of the pioneers were married couples. as therapists. It need not be a male-female pair. The genders are less important, but I think the concept of two therapists is very powerful indeed. Most of us involved in this kind of work are experienced in systemic or family therapy, so used to working in pairs. It's a very powerful combination to have two therapists. What was the second part of that question?
How long does the length? Yeah.
So most protocols have, as I said, a combination of non-drug and drug sessions, where the non-drug sessions on a weekly basis are outpatient psychotherapy, so just say 60 minutes, and the patient goes home. On the drug sessions, they are all-day sessions. The patient comes in at 9 a.m. and the session doesn't finish till 5 or 6 in the evening.
Yeah, thank you. And then there's a question here, is there pushback coming from any particular interest groups in the UK, e.g. Big Pharma, who are against the legalisation of psychedelic-assisted therapy?
Not that I'm aware of. People often ask, you know, is it because this is controversial, do the government block this or does Pharma block this? It's not been my experience at all. By far the biggest barrier to all psychedelic research is not some conspiracy theory irrational block from higher agencies. It's quite simply money. It costs an enormous amount of cash to do human psychopharmacology research of any type, psychedelics or otherwise. And most of the money involved in pharmacology research is coming from the pharma industry because they have a product to sell that allows them to reap back their R&D costs. So there hasn't been significant pushback from the pharma industry. The pharma industry has been peculiarly quiet about the whole thing. Maybe they just don't think it's going to be a significant competitor to them. Now that, of course, could change in the future because what psychedelic therapies offer is a radically different approach to the way we use pharmacology. It's allowing us to get away from daily maintenance therapy with medications into a short, effective, discrete course of psychotherapy, which means the patient doesn't need to sit on a daily drug anymore. So one might expect some kickback, but I haven't seen any thus far.
That's fantastic. And would you, I mean, I've got so many more questions here, but I wondered if you might briefly talk about your alcohol study as well.
Yes, so pretty much all the work with MDMA has been with PTSD, and it's come from MAPS. There was one study that used MDMA-assisted psychotherapy to treat social anxiety disorder in autism with adults. But other than that, it's all been PTSD. So when we got the opportunity for funding for an MDMA study, I was working in addictions at the time. I thought, well, let's branch out from that and try an addiction study because it's never been done. And the reason I thought this would be helpful is because, as I said earlier, my experience of mental disorders in adults is almost always about trauma. So we know that MDMA works for PTSD. And I was aware that patients with alcohol use disorder had high levels of trauma that underpinned their disorder. So we kind of put 2 and 2 together and said, would MDMA work as an addictions treatment? And so we had 14 patients in an open label MDMA-assisted psychotherapy study, all with a diagnosis of alcohol use disorder. We detoxed them all down to 0 in terms of their alcohol use. Then they went through an 8-week course of MDMA-assisted psychotherapy, which, as I said, involved 2 sessions with MDMA sandwiched between non-drug supportive sessions. And then we followed them up at 3, 6, and 9 months. And the results have been spectacular. So we did a previous study as treatment as usual study, an observational study to see how people did post-alcohol detox. And in that study, without MDMA, at 9 months, 76% of patients were back to their previous levels of drinking post-detox. With the MDMA study, 14% were back to their previous levels of drinking post-detox. Now that absolutely spectacularly blows out of the water the very best treatments for alcoholism at the moment. So it's better than AA, better than rehab, better than group or individual psychotherapy, better than anti-craving drugs. It's a spectacular result. Now, that was an open label, non-controlled, non-placebo controlled study. So more needs to be done and a randomized control study needs to be done. But it's a very promising start for the potential for broadening MDMA away from PTSD towards other conditions in psychiatry, and particularly addictions.
So exciting. And we have a number of addiction specialists in Australia who are very keen to meet with you when you hopefully come to Melbourne. But if not, we'll have to meet them with you virtually. There's some other questions here. How do you protect against neurotoxicity associated with MDMA use?
Wow. So the neurotoxicity argument is not one you hear much nowadays. When I started in psychopharmacology in the early 2000s, there was a sort of 50-50 split within the psychopharmacology community about MDMA neurotoxicity. That is now much more like a sort of 98% to 2% split. We've all moved on from the concept of MDMA causing significant neurotoxicity. We know this isn't a big problem. When we look at ecstasy use, we have massive wide-scale ecstasy use all over the world, and particularly in the UK. And we are just not seeing neurotoxicity. We're not seeing significant harms associated with even very heavy ecstasy use. And this is confirmed also by a lot of neurophysiological studies. So a lot of those scares that came out in the early 2000s have now been readdressed and reappraised. And this is, I'm talking about recreational ecstasy use, multiple uses of ecstasy. When we look at clinical MDMA use, and you only take the drug twice or maybe 3 times in a course, in a very carefully screened and monitored setting, the risk of neurotoxicity is virtually zero. And indeed, in all of the studies that have been done, none of the patients have demonstrated any neurocognitive deficits associated with clinical MDMA. So I think we need to readdress what we might have feared back in the 90s. It just hasn't turned out to be a significant issue.
I thank you for that. There's a lot of confusion, I think, still around. Ben, what's your experiences using MDMA with the additional help of nalmefene, naltrexone, etc., compared to just MDMA?
Well, of course, there's never been a study that prospectively explores these anti-craving drugs like nalmefene or naltrexone versus MDMA. So I can't speak for any science or data on that issue. It's not been done. What we do know, though, is that these anti-craving drugs are not particularly effective. Some of them have approximately a 20% effect above placebo when combined with therapies. So they're not magic wands by any means. And there's no reason why they can't be combined with MDMA. Patients can stay on those drugs whilst taking MDMA. I think I might have to check that. So yeah, there's no scientific data that compares them. But what we do know clinically is they're not that brilliant and in the first place. So I'm quite certain that MDMA would be more effective.
Thank you for that. And then this question, is this just the realm of psychiatrists, or can you envisage well, I think already is a future where a psychiatrist could prescribe the MDMA, but psychologists, psychotherapists and others conduct the therapy sessions? And I believe that's happening, but would you like to just explain that?
I can more than envisage that future. I can tell you that that is the future. A lot of psychiatrists don't necessarily make very good counsellors or therapists. And when we're looking at building up the pool of therapists for MDMA and other psychedelic therapies, they certainly don't need to be psychiatrists. I feel very strongly that they should be a clinician of some kind. So that could be a doctor, a nurse, a counsellor, a psychotherapist, clinical psychologist, a social worker, a physiotherapist, a podiatrist, an occupational therapist. I do feel strongly that clinical training of some kind in one of those disciplines is important. I get a lot of people contacting me saying, oh, Dr. Sessa, I want to be a psychedelic therapist. And I say, okay, why? And they say, because I love taking LSD. Now, in my opinion, that's not a good to become a psychedelic therapist. I think if you want to be a psychedelic therapist, first of all, become a clinician working without psychedelics in whatever discipline. Learn through many years of clinical experience about trauma, about patients. So a love of psychedelics, in my opinion, is not adequate reason to be a psychedelic therapist. You should love patients and working clinically, and then you add psychedelics later as a specialism.
Thank you. Great answer. A question here, does it matter if people have had previous, e.g. recreational experience with MDMA? The lady says, my impression is that the initial effects may not be replicable with repeated exposure.
Interesting question. So in our study, we took people either who were completely naive and have never had MDMA, or people who've used it in the past in the form of ecstasy. And there really was no difference between that. My own personal experience, having used both recreational ecstasy in the past and also having undergone clinical MDMA therapy as part of my training, receiving clinical MDMA, they really are not that similar. The way people take recreational ecstasy is very much an externalizing party type experience. And it's very different from the way we use it clinically. So all of our patients who had prior ecstasy experience, they all said, this is nothing like my past experience of taking ecstasy. So it doesn't make a lot of difference as to whether or not they've had MDMA in the past or not. Their responses to clinical MDMA are always quite unique.
Okay, and a question here is the exclusion of people with psychotic disorders based on specific evidence. Given the prevalence of trauma and the connection of the experience of psychosis with trauma, I'm curious about how and why this group is often excluded.
Yeah, good question. I mean, that's just been a pretty rigid narrative throughout all psychedelic research since the 50s, that psychedelics and now more recently MDMA should be contraindicated in cases of personal or family history of psychosis, such as schizophrenia or bipolar I disorder. Now, I personally think that's a narrative that's worth challenging, but at the moment it seems to be something that the ethics committees fairly rigidly insist, that you must screen out people with psychosis risk. And so most studies do indeed screen that out. And if you've had a history of psychosis, you wouldn't be eligible. I do hope that this is something we can review in the future. I think that psychedelics can best be seen as augmentation of psychotherapy. And so wherever psychotherapy is effective, then psychedelic-assisted psychotherapy or MDMA-assisted psychotherapy could be effective too, including potentially in cases of psychosis. But at the moment, it seems to be a fairly rigid rule that's imposed by ethics committees. And I don't see anyone getting around that in a hurry.
There's a question here, how do you deal with precarious trauma?
What does that mean?
I'm not quite sure. I'll find out shortly. MDMA therapy versus psilocybin therapy. Do you want to comment on that at all?
Yeah, so purists would say they're completely different. My opinion, I'm dual trained in both psilocybin therapy and MDMA therapy. And in my opinion, the similarities are greater than the differences. Of course, there are different compounds with different mental states, and there are different approaches to the way one conducts the psychotherapy, but the similarities are greater. You know, it's very much about using the altered state of consciousness as a platform for effective addressing of trauma and past experiences, and providing a safe platform in which the patient feels contained and empowered to do so. MDMA is predominantly a more tolerated drug. It produces a strongly felt positive affect that most people find pleasurable and tolerable. Psilocybin, of course, a classic psychedelic, can be more challenging for most people. It could go either way, but nevertheless, it's a very powerful experience. Both require high levels of support and management. And crucially, it's all about the integration and the follow-up. The drug experience itself is only a small part of a course of psychedelic therapy. Most of the sessions are non-drug sessions. And these are what are so important for both the therapeutic effects and also the safety of the treatment.
Mm-hmm. And we've got some questions here about serotonin syndrome, and do patients' experience come down several days after sessions? If so, what support is required, etc.?
So come downs, this is a really interesting point. So there's a very well-known narrative within recreational ecstasy users that you get a come down at the end of the night, and then you get this 3 day later post-affect blues, post-MDMA affect drop, like, what do they call it? Suicide Tuesday or Blue Monday or Black Wednesday or whatever. We did not see that. None of our patients over 26 sessions of MDMA experienced a come down. They all gently eased into the evening with a positive affect, and none of them got an affect drop 3 days or in the week afterwards. Indeed, they were all left with a week-long afterglow of positive affect. So I think that a lot of these narratives that arise from data from recreational ecstasy users are erroneous and need to be challenged, because when MDMA is taken clinically in a supervised setting, we just don't see those problems. I think there are so many confounding factors with recreational ecstasy use, mainly the purity of the drug and whatever other drugs are taken, but particularly missing out on sleep and food and excessive exercising or dancing. You're bound to feel unwell towards the end of the night, and 3 days later, it's a hangover in many cases. When you take the drug clinically at 10 o'clock in the morning with no other drugs in a supportive setting, and you're back down to baseline at 5 or 6 p.m., and you have a nice meal and a good sleep, you don't get those effects that we often hear anecdotally from ravers.
Mm-hmm. Very interesting. There's questions here about how people train to be a therapist. We have a certificate in psychedelic assisted therapies just launched, which we'll show you in a moment. So there's heaps of information about that. What we might do, I think a couple of people have raised their hands as well. Ilan, if you just share the screen quickly, I'll just go through a couple of the last slides, and then we might just see if anyone wants to raise their hand to ask Ben a question and unmute after that. So just looking at this particular slide here, this is Tim Ferriss's quote about the prospective nature of this field and how small amounts of money can actually have a huge impact on millions of lives. And next slide, I guess, and he's one of the great philanthropists in this space globally. Next slide, Ilan. So there's all sorts of ways that you can help Mind Medicine Australia, including starting conversations, volunteering, starting or joining our state and regional and rural chapters. We've got a great Learn section on our website. Talk to your doctors, your psychiatrists, medical professionals, get them all up the curve, connect them to us. We'd love to work with them and meet them. Of course, we're a charity, so my husband and I are philanthropists. We rely very much also on other philanthropy, which can be small, can be large, it can be in between, but we really encourage you to support us as much as you can. We run very leanly and we're working very fast to try and bring these medicines to as many people as possible in Australia. As well, talk to your local MPs, attend our summit, etc. And next slide, thank you, Ilan. So this is a certificate in psychedelic assisted therapies. This was launched 2 weeks ago. We've had a lot of applications from psychologists, psychiatrists, GPs, occupational therapists, social workers, mental health nurses, psychotherapists, all sorts of different types of therapists, addiction specialists and others. And we really encourage you to apply, because this will be the gold standard and it will count for a lot, both in terms of any trials that take place in Australia. It means that therapists who have this certificate will be more easily able to join those trials. And also in terms of, oh, that's very strange. Something really weird going on with my slides. Ilan, would you mind popping that back on there? Thank you. And then we're hosting a 2-day international summit preceded by a 2-day introductory workshop in psychedelic therapies in November in Melbourne, which Ben and others, if you go to the next slide, Ilan, you can see that incredible lineup of people that we hope to bring into Australia, borders COVID willing. And we look forward to welcoming you to that. We've got over 300 tickets sold for that so far. And the next slide is our upcoming webinars. These will be some more free webinars. There'll be some webinar and information session on the certificate. Next slide, please, Ilan. Maybe that's all. There's a few other, there's also a webinar coming up on addiction and around ketamine, ibogaine, and other psilocybin and MDMA treatments for addiction and so on as well. All right, so we'll go back now to the screen, open up the gallery, and we will see, I think I noticed before that someone had raised their hand. A couple of people have raised their hand. Ilan, would you be able to bring them up to the top or enable them to ask their question?
Everybody can now unmute themselves, so if they've got a question, by all means.
But don't all unmute yourselves at once. Andrea, I think you had a question, yeah?
Yes, for Ben, I wanted to ask, when it comes to integration after the fact, aside from continued psychotherapy, which is the most obvious benefit, do you have specific techniques and tools that you recommend?
Great question. What we do towards the end of the 8-week course with our study is you start talking about how they can use what they've learned in the MDMA sessions to go forward into life. And there's a lot around encouraging putting themselves back into that mental state through meditation or yoga or Pilates. We talk a lot about lifestyle change, improved diet and exercise, improved relationships. We encourage people to listen to the music soundtracks that they used in the MDMA sessions. And of course, we encourage them to just continue whatever other psychotherapies they're doing. You know, I think that this is good practice with any kind of medical intervention. It's not just a one-hit wonder. If it doesn't result in significant lifestyle change, then you're probably not doing it right. So there's a very strong emphasis on how they take this forward. They can't keep relying on taking MDMA again and again. It's about doing a course of psychotherapy that's effective, that results in meaningful change that they take forward. So a lot of emphasis, like I said, is put on how they can make these changes and continue those effects that they've learned.
Thank you. That's excellent. I noticed someone else's hand up. Ilan, did you?
Sean's got a question, I believe.
Sean? No, you don't? Okay. No problem. I noticed someone else's hand before. If you've got any last questions for Ben, please. Yes?
Could I, if you're on other my name's Tessa, if you're on other medications such as SSRIs or mood stabilizers, can you still do the MDMA therapy, or do you have to stop all the medication?
Good question. We take each case on a case-by-case basis and go through whatever medications a person is on. And there are some medications that should not be combined with MDMA and others that it's okay to stay on. So it really depends on what they are. When it comes to SSRIs, we do wean people off these, not necessarily because of an adverse reaction in combination, but more because SSRIs reduce the efficacy of MDMA. You don't get such a strong session effect if you're also on SSRIs. So yes, SSRIs are weaned off. There are some other medications that's important to keep taking, such as antihypertensive drugs for high blood pressure. And then there's a whole bunch that may or may not react with MDMA. So it's on a case-by-case basis. Ideally, the patient will not be taking any medication because you really want them in their sort of completely fresh state. So it's a case-by-case basis. But yes, SSRIs are not good to combine with MDMA because it reduces the efficacy of MDMA.
Thank you, Ben. There's a question, I think, from Baber. Baber, I just noticed. Baber, did you have a question?
Yes, I had a question. I already wrote the question, but okay, that was ages ago. So basically, I am a palliative care nurse's assistant. And at the moment, I am studying at the University in Canterbury. I'm doing my master's and I'm writing my dissertation about the death anxiety, which I obviously face every day with my clients, and psychedelics as tools to eliminate the death anxiety. Where exactly can I train in the psilocybin therapy? Am I allowed? I work in clinical settings anyway, so am I allowed to do that, and where can I start? I mean, I'm ready to start today.
So you're in the UK. You're in the UK, is that correct?
Yes. Yeah.
Ben might be on it.
Good question. Now, I get at least 10 emails a week, 5 of which on this subject. 5 of emails a week I get from patients wanting psychedelics. The other 5 I get every week are from clinicians wanting to become psychedelic therapists. Now, we're in a difficult position because at the moment, you can only formally train to become a specific psychedelic therapist if you have a research study to do. And MAPS provide the training for MDMA therapists, and Compass Pathways provide the training for psilocybin therapists for those people who are doing research studies. Now, this is creating a real problem because we're going to have this huge bottleneck, because if in a couple of years suddenly MDMA and psilocybin become approved and are available, there's only going to be a handful of therapists around the world who've done the training, those ones who happen to be doing the small numbers of research studies. So this situation has to change. And I think what Mind Medicine are doing in Australia is brilliant. And you're offering a psychedelic therapy training course. We're setting up a similar thing in the UK. There's a study at the California Institute of Integrative Studies that also offer a course. And I think more and more courses are opening up around the world to train as psychedelic therapists. But the difficulty is, unless you have a study to do, what's the point? Because you can't use them anyway. So we have a bottleneck. We need thousands of new therapists, but they can't practice once trained unless they're doing a research study, because then drugs aren't available outside of research. So just keep your ear to the ground. Do whatever courses you can. Be a good clinician outside of psychedelics. And as soon as we get drug approvals, then the doors will open and thousands of therapists will come forward. But in the meantime, have a look at whatever courses there are available. We're about to start one in the UK in the next few months.
Yeah, but where do I then find the information from?
You can email me.
Oh yeah, okay, thank you very much. Yeah, because I work in a hospice anyway, so, and in a palliative ward in a hospital, so yeah.
Yeah, you sound very well qualified to do the training. It's just, there isn't any yet in the UK, but there will be coming soon in the next few months.
Yes, okay, thank you very much for that, thank you.
And obviously we encourage everyone to register for the certificate here, and you'll be the ones who are leading the others, and also then can also train others, which will be very, very important. Let's just see if there are any other last questions. Ilan, do you see any? Christopher, is that you waving?
Yep. Hey, Ben. I'm not sure whether you can answer this question. Sorry to be so crass. I'm a psychiatrist in Australia, where a lot of the psychiatry is done in private practice. How is this economically viable for a psychiatrist, do you envisage?
For the psychiatrist, you mean, to make money?
Well, in order, if we're going to be trying to offer this to our patients, unless we're purely prescribers, I can't envisage how we can partake in the therapy and make it financially viable for the patients.
Oh, for the patients. Well, this is such a complex question. It depends how long you've got. It's all about individual countries' public health programs. And, places like the United States, which has a third world public health program, one of the worst in the world, are really struggling with this issue because they can't envisage anything in the public health sector, only privately. Other places like the UK that have an excellent NHS, this kind of work, it's no different from anything else. Most innovative new treatments, when they come out, are private because it takes a while for bodies like the NHS to carry out their assessments and evaluations and then decide whether it can be funded publicly. So, of course, when MDMA and psilocybin therapy first come out, they will primarily be in the private sector. But I see no reason why countries with good public health systems wouldn't eventually adopt these protocols. If MDMA and psilocybin therapies are safe and efficacious and have good results and get people out of mental health services and get them back to work, they will be adopted by public health systems and funded accordingly. In some ways, that's someone else's battle, not mine. My battle is to get these drugs approved and start getting them out there for what would initially be paying patients. But I will, if the NHS wish to pay, that's great. And that's a battle that has to be had locally in different countries. I certainly don't share the risk aversion and fear of a lot of members of the psychedelic community who say these treatments will always be exclusive and only for the rich. I think a lot of that narrative comes primarily from people in the United States who can't really envisage or conceptualize public healthcare at all, because they unfortunately live in such a poor country when it comes to public healthcare. Elsewhere around the world, if these drugs are demonstrated to be safe and efficacious, there's no reason why public healthcare systems won't adopt them.
And that's very much our experience here in Australia as well. Peter, did you want to comment on that at all?
Yeah, just to really reiterate what Ben said, that in the early days, this therapy will be private until we can convince the government of the day that this is actually an economically viable therapy. But as to track record,
if you look at any new treatments like EMDR, when that came out 15 years ago, 20 years ago, it was private. Now it's standard NHS treatment. Mindfulness, when that first came out 20 years ago, that was only private. Now it's standard NHS treatment. It's very normal that new innovative treatments start out private and then the NHS does its own evaluation and decides whether it's economically viable. I think that the proof's going to be in the pudding. I think it is economically viable. There's no doubt that psychedelic therapies are cost heavy up front. The cost of putting someone on Prozac is about 50 pence a month. The cost of a 10-week, 12-week course of MDMA psychotherapy could be 10 or 15,000 pounds. But actually, 10 or 15,000 pounds, if it works, cures the patient, keeps them out of psychiatric hospital for the rest of their lives, is a very economically viable treatment. So it's the sorts of therapies that are expensive up front, but if they work, and then they're very viable. What I think's lacking, and I'd love to see this, and I say this all the time, if there's any health economics people listening to this, I'd love to see a paper looking at the health economics of psychedelics, comparing the expensive upfront costs with the lifetime savings that they would give. I've not really seen much data on that, but it would be very strong if we could get that sort of paper out there.
And that is something that we're absolutely speaking to some potential consultants about, Ben. So we'll watch.
Yeah, I mean, when it comes to the cost of mental health care, you can cut corners left, right, and centre with poor, minimal psychotherapies, minimal medications. The moment you take a patient into hospital, you lose all your savings. It costs £5,000 to £10,000 a week to keep a patient in a psychiatric intensive care unit. You just lose all your savings. So any intervention that keeps people out of psychiatric hospital will quickly pay for itself.
No, thank you.
Peter's got a question.
One more question, last question.
Could I maybe ask a question, please?
Yes, Siobhan. Hello.
Hi. Hi, Ben. My name's Siobhan. I'm a clinical psychologist and mental health nurse from South Australia. And I've been speaking with a team in Adelaide. We're quite interested in starting some research trials up here. And I was just wondering, what kind of qualities would you say are best suited for a therapist conducting psychedelic research trials? Like, what kind of qualities would you look for in a therapist?
Well, I mean, like I said, there's a broad range of different people who could do it. And not everyone shares my opinion, but I'm of the opinion that you should be a clinician of some kind. Now, a doctor, a nurse, a psychiatrist, a psychotherapist, a psychologist, an occupational therapist, a podiatrist, a physiotherapist, a social worker, any of these clinical roles could be a psychedelic therapist. And in my opinion, being good within that discipline is the most important thing. I think you are far better skilled at managing a difficult psychedelic session if you have a wealth of experience of years of normal clinical experience than you are, as I said, someone who has lots of psychedelic experience, but clinical experience. So really, it could be any of those clinical groups. The first thing you need to do is go out and get your clinical training in one of those modalities. Now, of course, some of those take much longer than others. Becoming a doctor takes much longer than becoming a counselor. So choose your modality, choose your discipline, become an expert in your field, and then add on psychedelic therapies as a specialism. I mean, and the particular qualities really are working with patients who've experienced trauma and having the scientific and clinical experience of that patient group.
Mm-hmm. Yeah, thank you.
Thanks so much, Ben. Okay, so I think we have asked you enough questions for one night, or one day for you, but I would like to just acknowledge Ben. He's done a fantastic job answering a hell of a lot of questions in a very short time, and his commitment to this field is really inspirational, and also his courage to say things how they really are is something that I have enormous admiration for. So let's give him a big clap.
Tanya, that's very kind, and I'm very grateful for your support and inspiration for myself, and looking forward to coming into Melbourne. I mean, for me, psychedelics are not even that special. I know that sounds like a strange thing to say to the psychedelic community. I am just a hardworking, diligent, evidence-based, data-driven doctor whose absolute primary care is towards my patients and their well-being. And the reason I'm coming into psychedelics for the last 15 years is not because I'm a psychedelicized, I mean, I am a psychedelicized person. It's because they are the best medicine that I've come across in my 20 years in psychiatry. They really are. And they just simply work, and they're safe and they're efficacious. And it would be a huge folly to ignore the clinical potential of psychedelics and MDMA going forward, because the thing that motivates me is my patients. I work for my patients. They are my boss. They guide me with what they want and need, and I follow them. And they come to me with a lifetime of ineffective traditional psychedelic treatments, and they absolutely deserve to look at psychedelics and MDMA, because if it can improve the quality of their lives, it can improve the whole profession.
Yeah.
Just outstanding. Peter, did you want to say anything?
No, but Ben, just from me, thank you for participating in this in a bit busy schedule. It's brilliant having you as part of this seminar and answering the questions in the way that you have. It's fabulous.
And we love having you as an ambassador of Mind Medicine Australia, and just, you know, it's so important for people to realise, you know, that there are treatments and there is hope, and we just all need to step up and, you know, make sure that there is an expanded opportunities for caring clinicians like you.
Great. Well, I really hope I'm going to be coming to Melbourne. I've packed my swimsuit already.
Okay, well, let's hopefully make that as possible as we can, Ben. We certainly hope so. And thank you to everyone. We look forward to, we'll release our new webinar series very soon, and look forward to seeing you all very soon. If you've got any questions, of course, send them to the Mind Medicine Australia main email. And also, we do encourage people, each of you, if you've enjoyed this webinar, to bring 2 or more people along to the next one, because, you know, it's just by this process that we'll continue to educate people.
Thank you.
Thank you
Thanks
all.
very much.
Bye.